grateful for the organizers of giving us this opportunity to speak on the radiation aspect of lymphoma, which was historically the first treatment of lymphoma. So we will be discussing or learning about radiation in two parts. I'll be speaking about Hodgkin, and my colleague Dr. Nivedita will be speaking about non-Hodgkin. So we'll try to squeeze in maximum. And where's the slide? This one. Yeah. So we can start, I think. In today's learning objectives, we'll be talking about the indications for radiation in classical Hodgkin lymphoma and in non-Hodgkin lymphoma. And in non-Hodgkin lymphoma, if time persists, be going beyond marginal zone lymphoma and DLBCL or follicular lymphoma. We will also recognize how systemic therapy and diagnostic imaging influences radiation recommendations and dose, and how do we identify strategies to minimize toxicity and which are basically using different kind of techniques of radiation. So the role of RT in Hodgkin lymphoma is basically across the spectrum, starting from early stage, advanced stage to relapse and refractory. Starting with early stage, we have a case, a 30-year-old female with progressive right neck fullness without these symptoms, and on PET-CT found to have nodes in the right supraclav region and in the superior mediastinum. Biopsy demonstrated a nodular sclerosing Hodgkin lymphoma with an ESR of 8. So often in the clinic, we get this scenario. We need to ask ourselves that whether this is favorable or an unfavorable risk stratification. So for this risk stratification, we have the German Hodgkin group and the EORTC, and the NCCN has its own risk factors. What is important to note here is that German Hodgkin lymphoma group does not account for age, but accounts for the extralymphatic nodal involvement, and the EORTC accounts for age. And there is some difference in the way to calculate the mediastinal bulk. So this is how we calculate the mediastinal bulk. In EORTC, they take the mid-thoracic ratio, and in the German group, they take the maximum thoracic ratio, which is basically the tumor mass in the mediastinum divided by the maximum intrathoracic diameter, and this is the diameter at the T4, T5 level, which is taken by the EORTC. So this defines bulk. Another difference between the risk factors are the number of nodal sites. So it's 2, 3, 3. What we need to understand that these nodal sites are different from what is being shown in the Lugano or in the Ann Arbor classification. What is interesting to note is that mediastinum, right hilar, and the left hilar are both grouped as a single nodal site in the German and the EORTC risk stratification, whereas there is some difference between the right cervical and the infraclavicular and the supraclavicular in the EORTC and the German Hodgkin group. So what is important to remember is that whichever group stratification that we are trying to follow, we need to do the lymph node site involvement accordingly. So when we're talking about this patient of an early stage Hodgkin lymphoma, we basically have two strategies, and these strategies evolved from 2010. So one is the risk adapted approach, which I just spoke about. So what data do we have for that? Is basically the German Hodgkin lymphoma study group HD11 and the HD10 studies. And we have the PET adapted or the PET response adapted strategy. So we look at the German Hodgkin lymphoma group, HD10, a 2x2 cross-factorial design randomized trial, 4 cycles of ABVD, 2 cycles of ABVD, 20 gray of radiation. So in early stage with no risk factors, which I've just discussed, what was found out is that all the 4 arms or the groups had similar progression-free survival. So basically, from this, and this paper was published in the NEJM, and with this risk-adapted approach, times 2 and 20 gray of ISRT became the standard of care. So our patient undergoes PET, 2 cycles of PET, and we do not have any disease. So is there any approach which can tailor the radiation further? Is there any role of radiation further so as we de-escalate the toxicity? Before going to that, this is an important slide which I want all of you to see, that there is a difference in the reconstruction algorithm. So in this patient, the patient has a DVLO 1 and 2, and DVLO 1 and 2 is actually a complete metabolic response in most of the Hodgkin lymphoma studies, and 3 and 5 is a partial metabolic response. this is an example where the reconstruction algorithm that is being used to actually report on PET CTs may give you different D-value scores. This is an example where after chemotherapy, there was a right supraclav node, and on an OSEM algorithm, it gives a score of 2, but on a Q-clear algorithm, it gives a score of 4. So what is important here to note is that PET CT needs to be done from the same place, the response needs to be adapted from the same place, and the algorithms that we use need to be documented by the nuclear medicine, or you need to ask them. Otherwise, these kind of issues can lead to either over-treatment of your patients. So going to the response-adapted approach, we have the HD16 trial, which divided 1,150 patients into 2 arms, 2 ABVD, 2 times ABVD, and an interim PET. At the time of interim PET, the response was evaluated. Divolo 1 and 2 score were, as I said, CMR, and beyond that was partial response. So at PET, we followed the same 2010 paper and gave 20 gray of IFRT. And in the experimental arm, the negative PET went on towards observation, and the positive PET received 20 gray of IFRT. What was found is that this had a pre-specified non-inferiority margin to detect a PFS difference of less than 10%. So statistically, they wanted to have a 95% confidence interval, which was less than 10% to say that observation is non-inferior to radiation. But in this trial, the confidence interval was not below 10%, and it increased 10%. So this was a negative trial, which concluded that RT cannot be safely omitted after a complete metabolic response to 2 cycles of ABVD. So for our patient, we do recommend 20 gray of ISRT. Now, going to the historic era, before the event of chemo, we were using radiation to treat the disease systemically. That is, for such a small disease, we were treating the mantle field. And if it was an advanced disease, we were treating almost a total nodal irradiation. And this was from the 2D era, and this was the mainstay treatment for at least 20-30 years. And this resulted in a lot of toxicity, and because of which we are right now doing all the dose escalation and the dose de-escalation studies for radiation and trying to omit radiation. But now coming to the more advanced techniques of radiation, we are only exposing the body limited volume, and now it is going to the 3D era. So a little bit teaching on what is ISRT, what is INRT, what is IFRT, because it's always been confusing. So this slide gives a timeline of how radiation was used to treat such a patient, which I have discussed. What extended field RT does is that in a stage 2, stage 1 unfavorable, in favorable patients, we used to initially treat the cervical nodes, the axillary nodes, and the mediastinum nodes. I would have treated this patient in the 1960s like this. And in the 1980s, with the event of ABVD, we tried to reduce our field, then we omitted axilla, because axilla was never involved in this patient. Going towards the late 2000s, we have something called as the INRT or ISRT, which basically treats the pre-chemotherapy gross tumor volume. And here we try to restrict our volumes to the pre-chemo disease using 3D-based planning. So this is another example. This is a disease in the mediastinum, superior mediastinum to be precise. This is a pre-chemotherapy CT scan. Chemotherapy, and you can see this pink outline demarcates the pre-chemo gross tumor volume. We give chemotherapy, and we have a partial response to a complete response in this patient. So this is the post-chemotherapy volume. So if you look at this green outline is the residual disease post-chemo, and this pink outline was actually the disease pre-chemo. So you can see this pre-chemo disease, or pink outline, goes and superimposes inside the lung, which was never involved in the first place. So ISRT uses these anatomical landmarks that were previously involved or not involved, and we are able to adapt the volumes post chemotherapy to reduce the toxicity. Now, what is INRT? INRT is basically if we have the diagnostic PET CT in the treatment planning position. Why in the treatment planning position is because of the registration. We do a CT to CT matching at the time of planning. And if this CT to CT matching is erroneous because of the issues of the tumor smaller and the volumes becoming smaller, so the fusion or the CT to CT matching is not adequate. So because of this, ISRT will also have a little larger volumes than involved nodal RT, but you can really reduce your volumes by doing a PET in the treatment planning position, that is the diagnostic CT. Then you can really curtail to the tumor volumes. So why this issue of small fields? So does reducing the field, we need to ask this question, does it really compromise on the oncological outcome? So the answer is no, it does not. And this is being shown by this slide, which shows equal PFS for the INRT field, IFRT field, or the EFRT field, which I've just shown. Now, does reducing the field reduce the toxicity? So we don't have randomized trial data on that. We do have a lot of retrospective and some prospective data, which shows that the British Columbia group showed that the mantle field and the risk of breast cancer was very high with the mantle field, and it is very low with the IFRT or the ISRT or the INRT approach. The same goes with the Dutch data. So what we are trying to show is that ISRT or INRT is able to have the same oncological outcome and also reduce the toxicity, and this is what we want. So another similar case, can the radiation toxicity be reduced further with ISRT or INRT? Well, the answer is yes, because we have a toolkit or an armamentarium of different techniques as radiation oncologists that we can use to reduce the radiation dose, namely deep inspiratory breath hold, a 4D CT, proton therapy, or image-guided radiotherapy. So what is this DIBH or deep inspiratory breath hold? Normally, we use this for breast cancers to reduce the hard dose, but we also use this in superior mediastinal lymphomas to reduce the hard dose. Here you can see once a patient takes a deep breath and is treated with that, the heart moves down, the lung expands, and it shields the heart. So you can see the dose actually to the heart goes from 7.2 gray to actually 2.8 gray. And this is actually very beneficial for the patients in the long run because the heart toxicity manifests after 15 to 20 years. This is another case, a 33-year-old female, lump in the throat, left neck swelling, nodular sclerosing Hodgkin lymphoma with a bulky mediastinum and supraclav nodes, hilar nodes, no B symptoms, ESR. So we risked as an early unfavorable Hodgkin lymphoma. Now, what data do we have for the unfavorable group, whether there is a need of radiation post chemotherapy? So this randomized trial, again a 2x2 design, tried to study 4 times ABVD with 30 gray, 4 times ABVD with 20 gray, 4 times BA-COP with 30 gray, and 4 times BA-COP with 20 gray. So if you can see, all the 3 arms almost had a similar survival except one, the one in yellow, which refers to the ABVD, 4 times ABVD to 20 gray IFRT. So what was found out with this risk-adapted approach, that all other chemotherapy regimens, which I've just mentioned, will provide a decent or a similar PFS, except ABVD times 4 with 20 IFRT in unfavorable early stage Hodgkin lymphomas. So, and it also showcases that the dose de-escalation of radiation from 30 to 20 can happen, but it has to depend on the chemotherapy backbone. If you're using an escalated BCOP, then we can go to 20 gray. If not, we'll 30 gray. Now, is there a response-adapted approach for early unfavorable Hodgkin lymphoma? So this issue was addressed by the UK RAPID trial, where it divided into 2 arms based on the PET negativity. And another trial was the EORTC trial with a favorable group and the H10 unfavorable group. Giving a brief summary of this cohort and the design. So what we need to understand that the UK RAPID trial actually had 602 patients with 426 PET negative, and they actually had 64% favorable by the EORTC criteria. Here, the non-inferiority statistical power was kept at 7% difference at 3 years PFS, and the non-inferiority for EORTC was less than 10% at 5-year PFS. So what was found out with this trial is that both did not reach their statistical significance. And what was concluded is that RT cannot be safely omitted for in the ABVD chemotherapy arm or ABVD chemotherapy, even with the negative PET CT. You can see the progression-free survival crossed the 95% confidence interval at 8.8%. So on the other hand, you may argue that this is a statistical power which I'm talking about. And I'm talking about is at a the difference of PFS is actually low. It's about 4%, or the mean PFS difference. So you can sit with a nuanced decision making with your patient, talking about the toxicity outcome of a smaller field radiation versus a PFS benefit of about 4%, or it may range from 1.3% to 8.8%. So this really involves a nuanced decision making with the multidisciplinary setting. But as of now, the data, we cannot safely omit radiation in ABVD chemotherapy. On the other hand, the EORTC trial had to be stopped earlier because it was a futile activity, as it was never going to achieve the non-inferiority significance which was initially marked. Going to the, so as I said, ABVD chemotherapy, if you talk about a hybrid-based chemotherapy with 2 cycles of ABVD and 2 cycles of BioCop, can we omit radiation? So the answer with this trial was the German Hodgkin lymphoma study group HT17. The answer was yes. So where the progression-free survival was similar between both the arms and it reached its statistical significance. So the answer is for ABVD chemotherapy in early unfavorable, RT cannot be safely omitted. With escalated BioCop or a hybrid approach, RT can be safely omitted in early unfavorable disease. So what do I do for my clinical practice?
You have 5 more minutes.
Yeah. So what do I do for my clinical practice? So we do. So I'll just skip this slide and I'll go for the role of RT in bulk. So this was the Italian trial which tried to showcase the role of radiation in bulky disease in 2007, which showed that bulky disease more than 5 centimeter did have about 10% benefit in PFS. But really, the new studies with ABVD chemotherapy and the latest chemotherapy, which basically showed that for bulky disease in early stage Hodgkin lymphoma or in advanced stage Hodgkin lymphoma who have PET negative disease, RT can be omitted with patients because the PFS benefit was within the pre-specified confidence interval. So is there any benefit for radiation in the residual disease arm? So the HD12 and HD15 answer this question, where the presence of partial or D value 3 to 5 does end up getting radiation. So they have a PFS benefit, and this PFS benefit is actually quite high. So radiation is actually given for patients with residual disease for advanced stage Hodgkin lymphoma. So for my clinical practice, I go for, in advanced stage Hodgkin lymphoma, I go ISRT in case of partial response, no consolidation for initial bulk after CMR, exception in stage 2, because stage 2 was actually higher in Italian randomized trial and the other stratified groups. So going to the role of radiation in refractory or relapsed Hodgkin lymphoma after autosomal after autologous stem cell transplant in unirradiated patients. So if you look at the patterns of failure, there is no randomized trial data, but when we look at the patterns of failure, the bulk of the treatment failure happens in the old sites or diseases that could have been covered with the field of radiation. So there is indeed some evidence to show that radiation to the initial bulky disease or to the previous size post ASCT can actually help in progression-free survival. So going towards, I think this is not working. Yeah. So for relapsed and refractory Hodgkin lymphoma, as I said, my indication for first relapse is that so 36 to 45 gray cytoreduction after salvage chemo or consolidation after the stem cell transplant. And for relapsed and refractory, we actually consider this as more as a palliative setting and not the curative setting. I think, yeah. So I'm done.